Hello everyone. So today I'll teach you about the topic malabsorption. So malabsorption ko first of all you have to categorize, like it can be a problem inside the lumen, right? So if it's a problem inside the lumen, when this is the cause, then it can be due to pancreatitis, because your pancreas produces enzymes which are responsible for the digestion. Okay, if your enzymes are not there, like lipase is not there, so you will not be able to form micelle. The digestion won't happen, so you won't be able to absorb these things. So if you cannot digest, see, digestion is the first step, breaking down the complex molecules into smaller molecules so that they can be absorbed. So it's very easily understandable why pancreatitis will cause malabsorption, because your digestion will not happen. Then cystic fibrosis. Why in cystic fibrosis you have malabsorption? Because we remember that in cystic fibrosis there is thick secretion. There is a thick secretion that obstructs the pancreatic duct. So thick secretion is obstructing the pancreatic duct. As a result, pancreatic enzymes won't be able to come into the duodenum. So it's a pancreatic duct obstruction that causes inability to secrete the digestive enzymes, like amylase for carbohydrate, protease for proteins, lipase for fat. So that is why cystic fibrosis causes malabsorption. So luminal causes, first we discussed pancreas, the pancreatitis, cystic fibrosis. Now next is bile salt deficiency. Now why bile salt deficiency will cause malabsorption? Because these bile salts are responsible for the emulsification of fats and formation of micelle. Remember what is a micelle? Micelle is a spherical structure. It has a core, it has an outer surface. Inside the core we have all these fatty acid, monoglycerides, cholesterol, fat soluble vitamins like A, D, E, K. They are all inside the core. Fatty acids, monoglycerides, cholesterol, and fat soluble vitamins, they are all present in the core part. And the outer surface is made up of these bile salts. Bile salt, I'll write it BS. Bile salt make up the outer surface. Bile salts, their inside is hydrophobic and outside is hydrophilic. Inside is hydrophobic, outer surface is hydrophilic. So this micelle formation is for this micelle formation you need the bile salts. So bile salt deficiency will cause inability to form micelle and emulsification. Why somebody can have a bile salt deficiency? Any condition that causes cholestasis, so that bile is not coming. It can be a CBD duct stone, common bile duct stone. It can be any reasons. It can be stricture in the CBD, CHD, or the gallbladder pathologies, wherever, or liver is not able to produce bile. So any condition that causes cholestasis, the bile is not coming, so you will have bile salt deficiency. And what is emulsification? Suppose you have a large fat globule. This is a large fat globule. Now emulsification is breaking it down into smaller fragments. This is emulsification. Bile salts are important for the emulsification. This fat globule, this large fat globule will now become small fat globules. This is what bile salt did. Now these smaller fat globules, their surface area is now increased compared to what their surface area was initially, right? Initially whatever was the surface area, now it has become more. Now because the surface area is increased, so the enzyme lipase can work on it easily. By increasing the surface area, the lipase enzyme gets more area to act. How bile salt breaks down this single large fat globule? Because bile salts are amphipathic. I just told you that they have a hydrophilic part as well as hydrophobic part. Anything that is hydrophilic as well as hydrophobic, they're called amphipathic. Because they're amphipathic, their hydrophobic parts will stay. Again, I'll draw. If it is a bile, it is a fat globule which has been broken down. How it was broken down? Because the bile salts, suppose these head ends, these rounded ends are the hydrophobic part, and the rods are hydrophilic part. Because of their amphipathic nature, they break it down. It surrounds the fat droplets and break them. So it is clear to us that pancreatitis will cause malabsorption, because the enzymes are not there. Digestion cannot happen, absorption cannot happen. Cystic fibrosis, thick collection blocking the pancreatic duct. If I ask you a few questions about cystic fibrosis, will you be able to answer? Tell me which gene is mutated in cystic fibrosis. I'll give you 5 seconds. You can recall? Yes, obviously you can recall. But what is the full form of this CFTR gene? Cystic fibrosis transmembrane conductance regulator gene. Cystic fibrosis transmembrane conductance regulator gene. Correct. Now if I ask you where is the which chromosome this gene is present, right? Which chromosome this gene is present? Well, it is present in the chromosome number 7. Correct. Most common mutation is the delta F508 deletion. Most common deletion of the amino acid which is present in the 508 position of CFTR gene. What is the amino acid which is present in the 508 position? Delta F508 deletion. That's what we are saying. In the 508 position, we have phenylalanine. And how it is transmitted? It is autosomal recessive. If I ask you what is the gold standard test for cystic fibrosis, how do you confirm it? What is the gold standard test? Sweat chloride test, where if you find chlorine levels more than 60, if you find it more than 60, it is confirmatory. So it's a gold standard test. Genetic testing like CFTR mutation, these are very costly. CFTR mutation, these are all very costly tests, but sweat chloride test is very much possible to do. Another cause, so we discussed pancreatitis, we discussed cystic fibrosis, we discussed bile salt deficiency. All of these are causes of intraluminal causes of malabsorption. Then Zollinger-Ellison syndrome, we know what is it. It's a gastrinoma. There is a tumor in the gastrinoma triangle known as Passaro triangle. This tumor, gastrinoma tumor, which is present inside this gastrinoma triangle called the Passaro triangle. This gastrinoma is producing a lot of gastrine. This gastrine is going to produce a lot of HCl. This HCl inactivates the enzymes. In the duodenum. It inactivates the enzymes in the duodenum. In the duodenum, the enzymes will get inactivated due to the excessive amount of HCl. So Zollinger-Ellison syndrome causes malabsorption. Okay, now coming to mucosal causes. So we discussed 4 important causes of intraluminal causes of malabsorption. In the mucosal causes, we know celiac disease is there, tropical sprue is there, Whipple disease is there, right? Giardiasis. Then other causes like autoimmune enteropathy, radiation enteritis, eosinophilic gastroenteritis, gastroenteritis. Now we will discuss celiac disease. What do we know about celiac disease? A few things we know about celiac disease, that it is due to the protein gluten. Well, inside the gluten there is a small peptide part. So gluten is this thing, long protein. Inside this long protein there is a small peptide part called gliadin, which is the main culprit here. This gliadin is resistant to digestion. It is resistant to complete digestion by the enzymes. इसका digestion अच्छे से नहीं होता. It is resistant to complete digestion. See what happens. This undigested gliadin, when it goes inside the mucosal cells of the intestine, inside the small intestinal mucosa, it reaches intact. Once it reaches intact, then beneath the mucosa is lamina propria. So suppose you have a mucosa, upper layer. Immediately below the mucosa you have the next layer called the lamina propria. I'll write it in short, lamina propria. Yeah. Mucosa, when we say mucosa, it is made up of 3 layers. Epithelium, that is what I meant to say, that these are the epithelial cells. Beneath the epithelial cell is this layer called lamina propria. So beneath the epithelium is the lamina propria, and beneath this is a muscle layer, very small muscle layer known as muscularis mucosa. So it is a muscularis layer of the mucosa. So epithelium, lamina propria and muscularis mucosa, these 3 together combinedly form the mucosa. Beneath the mucosa is submucosa. Beneath the submucosa is the muscularis propria, which is also called muscularis externa. And then lastly we have serosa. In extraperitoneal organs like esophagus, like the duodenum, which is majority extraperitoneal, then ascending colon, descending colon, in these areas we don't have serosa. Instead we have adventitia, which is a very loose connective tissue. But in serosa we have both the connective tissue as well as mesothelium. So presence of the mesothelium differentiates serosa from adventitia. In adventitia you only have connective tissue, but in serosa you have connective tissue plus the mesothelium. Back, so gliadin reached this layer, lamina propria. Once it reaches the lamina propria, inside the lamina propria, I'll draw, there is an enzyme which is written in short like this, small t, capital T, capital G. It is tissue transglutaminase. This tissue transglutaminase enzyme, which is present in the lamina propria, what it will do, it will cause deamidation of the gliadin. So now this gliadin is even more dangerous. Now it is a deamidated gliadin. Now once it is deamidated, means the amide group is removed. The amide group is removed. Now it becomes a negative charged gliadin. Now it becomes a negatively charged gliadin. Now this negative charged gliadin will be taken up by the antigen presenting cells, APCs. These APCs will take up this negatively charged gliadin and will express it on their surface. Suppose this is the deamidated gliadin. This deamidated gliadin will be taken up by the antigen presenting cells and it will be expressed on their surface, and the immune response will get triggered because this antigen presenting cell will present it to the CD4, ऐसे नहीं लिखते, CD4 plus T cells. This deamidated gliadin will be presented to the CD4 plus T cells, and they will activate further cells, which will result in the inflammatory response. And body will start producing autoantibodies, mainly targeting the gliadin and the TTG, tissue transglutaminase, because this enzyme converted the gliadin into deamidated gliadin. So antibodies target, the autoantibodies target gliadin as well as TTG, but mainly the TTG. This is the main target. Tissue transglutaminase becomes their main target of the autoantibodies. And accidentally, while attacking the tissue transglutaminase enzyme, they also attack the endomysium. What is endomysium? See, muscle fiber is covered by 3 layers. Endomysium, outside the endomysium is perimysium, outside the perimysium is epimysium. Just like your heart, endocardium, pericardium and epicardium. Similarly here also endomysium, perimysium, epimysium. Now accidentally this autoantibody attacks this endomysium, which is the innermost covering of the muscle fibers. So it produces endomysial antibodies, EMA, endomysial autoantibodies. So these 3 antibodies we have while diagnosing celiac disease. First of all, the anti-TTG. This is the most sensitive antibodies. It is highly sensitive, but if you have to check for celiac disease, you should always check along with that IgA levels. Okay, because your anti-TTG is present as IgA autoantibodies and IgG autoantibodies. In patients with IgA deficiency, the anti-TTG that we order is mostly IgA. IgG anti-TTG is not ordered that much. So whenever you are suspecting celiac disease, order both at the test simultaneously, anti-TTG, IgA and IgA total levels. If it is deficient, then you order for anti-TTG, IgG. It's a costly test, anti-TTG, IgG, because not done frequently. Now you can be very sure that the patient has celiac disease, but to confirm it, you check for the EMA, endomysial antibodies. EMA is the most specific, but it is not the most sensitive. So first you ordered anti-TTG with IgA. If IgA comes less, you order for IgG anti-TTG, and for confirmation you order endomysial antibodies. And we know that this gluten, it is present in wheat, barley and rye. So you tell them to completely avoid any gluten containing food, and to check the response, how do you check the response of the treatment? You check the response of treatment with this anti-TTG. So anti-TTG helps in screening as well as for treatment response. Now a few things, MCQ questions. We know HLA, DQ2 and DQ8, they have strongest predisposition, so not everyone will have gluten sensitivity. HLA DQ2, HLA DQ8 people have more chances of having this disease. And here you will have a lot of symptoms. So malabsorption के symptoms जो होते हैं, we haven't discussed them, so let me tell you the symptoms of malabsorption. First one is obviously steatorrhea, that is fatty stools. Confirm steatorrhea is present or not, you have to check 24-hour stool level. If it is more than 7 grams, the total stool content, it is a steatorrhea. If you have steatorrhea, that means you're not able to absorb fat. You lose vitamin A, D, E, K. These are the fat soluble vitamins. You will lose them. Also, you will have iron deficiency anemia, because celiac disease mostly affects duodenum. So when you hear somebody having celiac disease, they will tell them ki I went to a gastroenterologist and he ordered a duodenal biopsy. Now your question is, why duodenal biopsy? Why not jejunal? Why not ileal? Because celiac disease mostly affects the duodenum, and duodenum is the site for iron absorption. Okay, so you will have iron deficiency anemia. And in the duodenal biopsy of celiac disease, what you will find, uh, histological grading. So histological grading, which you find in a duodenal biopsy of patient with celiac disease, is called Marsh classification. Actually, we currently use the Marsh Oberhuber classification. Marsh Oberhuber classification of the grading of the celiac disease. So first we have 0, then we have 1, 2, 3A, 3B, 3C. These are the 6 stages of Marsh Oberhuber classification of the histological grading of celiac disease. In the first 0, the histology looks absolutely normal. In the next stage, we have increased levels of intraepithelial lymphocytes, IEL, a lot of IEL, increased IELs only. Next step, we have IEL plus the crypts become hyperplastic. Crypts become hyperplastic. There are a lot of cells now in the crypts. So you know, in the histology, we have the villi, the projections, and then we have crypts. These are the villi, these are the crypts. First stage, there is only in stage 1, there is one, we have the cells, IELs in the lamina propria. Okay? We have IELs in the lamina propria. Next stage, IEL along with that hyperplastic crypt. Next, from 3A, 3B, 3C, we start to see villus atrophy. So villus atrophy, if you see, it is at least 3. If it is partial villus atrophy, it is 3A. If it is subtotal, it is 3B. If it is total villus atrophy, it is 3C. So 3C is total villus atrophy. 3A is partial villus atrophy. 3B is subtotal villus atrophy. So first stage, there is only IEL. Next IEL plus crypt hyperplasia, then partial, then subtotal, and then total villus atrophy. 3A, 3B, 3C. This is the Marsh Oberhuber classification that is in duodenal biopsy for a patient with celiac disease. Very unique characteristic feature of celiac disease that happens in these patients, which is unique to celiac disease, not happen in any other condition, is dermatitis herpitiformis. You know this. Now you know what is the treatment. Yes, it is not just gluten-free diet, because yes, the pathology is gluten because it is related to celiac disease, but also you give Dapsone. What is Dapsone? Dapsone is a dihydropteroid synthase inhibitor. How it works, I'll explain. So Dapsone enters inside the cell, and this is the bacterial cell. So inside this cell we have PABA. Bacterial cells produces folic acid from PABA directly. FA, I'll write in short. FA stands for folic acid. So they produces folic acid directly from PABA, but humans cannot. So first the PABA becomes dihydropteroic acid, and then it becomes a folic acid. Now this conversion of PABA into dihydropteroic acid, this is done by the enzyme dihydropteroate synthetase. Dihydropteroate synthetase. Now this enzyme will convert PABA into DHPA as well as Dapsone. So Dapsone competes with PABA, and this will bind to DHPase, dihydropteroate synthase, and instead of PABA becoming DHPA, Dapsone will get converted into something else. So what it is doing? It is doing competition with PABA. As a result, we have decrease in the numbers of folic acid. Folic acid नहीं होगा तो क्या होगा? if we have decreased DHFA, dihydrofolic acid, the first step is DHFA formation and then it will become tetrahydrofolic acid. This is also you should know. PABA becomes DHPA, dihydroturic acid, then dihydroturic acid becomes dihydrofolic acid, DHFA. Then dihydrofolic acid becomes tetrahydrofolic acid. So you have less amount of folic acid. This folic acid is required for the DNA RNA, because in the DNA RNA we have uracil. For that we need folic acid. No, wrong, sorry, not uracil. Tetrahydrofolic acid is required for the purine ring synthesis. It is required for purine ring synthesis. Purines, we have adenosine and guanine. So the formation of adenine guanine, it will get hampered. Purine ring synthesis. So the pyrimidine ring synthesis. Pyrimidine ring synthesis also requires DHFA. So ultimately, with the absence of folic acid, you have absence of DNA synthesis, RNA synthesis. They are defected. But this is not how Dapsone works in Dermatitis herpitiformis, because we don't have a bacteria here. We have neutrophils which are attacking. So what Dapsone will do here is Dapsone will enter the neutrophils. So it will enter inside the neutrophil. I'll write in short N, neutrophil. What I just discussed before, it was the anti-bacterial action of Dapsone. But Dapsone also has anti-inflammatory action also. This anti-inflammatory action is used in treatment of Dermatitis herpitiformis. So Dapsone accumulates inside the neutrophils. Inside the neutrophils, we have now Dapsone. This Dapsone will inhibit the enzyme MPO. Inside the neutrophil, you have this enzyme myeloperoxidase. It will inhibit the myeloperoxidase and other enzymes. Myeloperoxidase is responsible for production of reactive oxygen species. Myeloperoxidase is responsible for production of reactive oxygen species. So you have less amount of production of reactive oxygen species and also other inflammatory mediators. Inflammatory mediators. So Dapsone inside the neutrophil decreases the production of MPO. MPO नहीं होगा तो decrease ROS, decrease inflammatory and decrease inflammatory mediators. Decrease inflammatory mediators, तो that means decreased neutrophil chemotaxis, resulting in reduced inflammation.